Okay, so welcome back to the session, which is gynae revision session for FMG specifically and also for Neet PG. Now, just now before the break, we were talking everything related to primary amenorrhea. We were talking everything related to menstrual cycle. Now I have to talk to you about syndromes in gynae. And as far as your FMG exams are concerned, this is all what you will be asked from PCOS, endometriosis, fibroid, whatever I'm going to talk to you now. Now, understand that PCOS or polycystic ovarian syndrome, I'll be covering only that part which is being asked in the exam, right? Most of that part quickly I'm going to revise with you, but there is lots and lots more to PCOS. This is not all PCOS which I'm going to make you revise here. The entire PCOS I'm not doing over here, yes? The diagnostic criteria for PCOS or for which is also PCOS, which is also called as the Steen-Leventhal syndrome, right? That is called as Rotterdam criteria. What is it called as? Rotterdam criteria. Rotterdam criteria says that any two of the following three should be present, right, to diagnose your patient as having PCOS. What are any two of the following three? Number one, there has to be increased androgen levels. Increased androgen levels. This increased androgen levels, they could be either present biochemically, right? So biochemically, by looking at the testosterone levels, if testosterone levels are increased, you come to know that there is increased androgen levels. Or number two, by hirsutism. That is clinical manifestation of increased androgen levels. Remember, normally in a female, androgen levels are less than 70. In patients of PCOS, the levels are between 70 to 200. Main source of androgens, main source of increased androgens in a patient of PCOS is ovary. Ovary is the one which is producing major source of androgen in patients of PCOS, right? Number two diagnostic criteria is ovulatory dysfunction. Ovulatory dysfunction manifested by either oligomenorrhea or amenorrhea, right? That's the second criteria. And what is the third criteria? Batao, what is the third criteria which comes under Rotterdam criteria? Which third criteria comes under Rotterdam criteria? Jaldi batao. It's polycystic appearance of the ovaries on ultrasound. What do you mean by polycystic appearance of the ovary on ultrasound? This means that more than equal to 12 follicles should be present. The size of the follicles should be between 2 to 9 millimeters in one or both ovaries. Or the volume of the ovary should be more than 10 cc. That is the diagnostic criteria for PCOS. Rotterdam criteria. Rotterdam criteria कहता है that out of these three, any two should be present to make a diagnosis of polycystic ovarian syndrome. Please remember, generally, this is how a polycystic ovary is going to appear on ultrasound, and usually the follicles which you are getting, they will be arranged around the periphery of the ovary, and this is what is called as necklace appearance. This is called as necklace appearance, right? But understand, generally in a patient of PCOS, the follicles are arranged around the periphery giving a necklace appearance, but necklace appearance is not a diagnostic criteria. So what is not a diagnostic criteria? Necklace appearance is not a diagnostic criteria. So this means that suppose if 12 follicles are present, even in the center of the ovary, that's okay. Rotterdam ये नहीं कह रहा है कि it has to be present around the periphery. Rotterdam कह रहा है more than equal to 12 follicles should be present. अब वो चाहे periphery में हो चाहे वो center में हो, it has to be taken as polycystic appearance on ultrasound. Right? Number two, obesity is not a criteria to diagnose PCOS. Nowhere Rotterdam criteria is saying that a PCOS female has to be obese. Number 3, LH is to FSH ratio is not a diagnostic criteria. Please remember, normally LH is to FSH ratio is 1:1. In patients of PCOS, this becomes 2:1 or 3:1, but this is not a diagnostic criteria. Next important question which they can ask you is that this LH and FSH, on which day should you be testing? You should be testing for LH and FSH on day 2 or day 3 of the cycle. Fourth criteria which is not a part of Rotterdam criteria is insulin resistance. Insulin resistance is seen in patients of PCOS, but it's not a diagnostic criteria. So these are not a diagnostic criteria in patients of PCOS. Then, whenever they ask you what is the first step in management of PCOS, always the first step is lifestyle modification. That is the first step in all patients of PCOS. As such, there is no drug of choice in PCOS because management is going to depend upon the symptoms with which a patient is going to come. So, management of PCOS depends on the symptoms with which a patient comes. Right? But overall, just in case they are hell-bent upon asking you what is the drug of choice, then the drug of choice is OCPs. Whenever you are using OCPs in a patient of PCOS, please remember progesterone should belong to 3rd or 4th generation. So you should be knowing what are the progesterones which come under 3rd generation progesterone. Which progesterones come under 3rd generation progesterones? Progesterones which come under 3rd generation are norgestimate, gestodine and desogestrel. And which progesterone comes under 4th generation? In 4th generation we have cyproterone acetate. Cyproterone acetate. No beta. Other than oligomenorrhea or amenorrhea, if your patient has come to you with menorrhagia, metrorrhagia, menometrorrhagia, they are not a diagnostic criteria for PCOS. Only diagnostic criteria are these. If patient comes to you with oligomenorrhea or amenorrhea, that is a diagnostic criteria. Other than this, if a patient is coming to you with any other complaint related to menstruation, that's not a diagnostic criteria. Then, what is the drug of choice for infertility in PCOS? As I said, the first step always has to be weight reduction or lifestyle modification. After that, the first line drugs for managing infertility in PCOS. First tell me, infertility in PCOS, what is the reason? The reason for infertility in PCOS is an ovulation. Right? So the first line drugs are ovulation inducing drugs, and in which the drug of choice is letrozole. Letrozole, that's the drug of choice, followed by clomiphene citrate. Why is letrozole a drug of choice? Letrozole is a drug of choice because it is associated with higher live birth rate and higher pregnancy rates than clomiphene citrate. Right? Clomiphene citrate and letrozole, both of them, their prerequisite is they require an intact hypothalamic pituitary ovarian axis to act. They can act only if HPO axis is intact. That is, FSH levels should be normal. Then only you can use letrozole or clomiphene citrate. Now, if they ask you what is the most common side effect of clomiphene citrate? Most common side effect of clomiphene citrate. What's the most common side effect of clomiphene citrate? Tell me. What's the most common side effect of clomiphene citrate? जल्दी बताओ. Who's going to tell me that this answer? Most common side effect of clomiphene citrate? Twin pregnancy, Dr. AM. और कौन बताएगा most common side effect? Excellent. Harshul, not twin pregnancy. Atul, K drama, and Deepak Kumar. Awesome. The answer is hot flashes. Most common side effect of clomiphene citrate is hot flashes. What are the chances of twin pregnancy with clomiphene citrate? What are the chances of twin pregnancy with clomiphene citrate? Chances are 5 to 8%. Second line drug. In second line drug, we have HMG. HMG is human menopausal gonadotropin. Human menopausal gonadotropin. HMG, it has FSH and LH. FSH and LH, and this is a drug which is most commonly associated with ovarian hyperstimulation syndrome. Third line drug for management of infertility due to PCOS is pulsatile GnRH. Right now, please understand, in patients of PCOS, there was an outdated surgery which was used in PCOS, and this outdated surgery which was used in PCOS was called as laparoscopic ovarian drilling. Laparoscopic ovarian drilling. But nowadays we don't use this surgery. In this surgery, the stroma of the ovary was burned. The stroma of the ovary was burnt. Right, now the stroma of the ovary has theca cells. So because theca cells were burnt, there won't be any androgen production. And if there won't be any androgen production, then the levels of androgen would decrease. That was the principle behind this surgery. But this surgery is no longer used because जब हम ovary को burn करते हैं, there are high chances of premature menopause. That is why we don't do this surgery. But in your FMG exam, they had asked, laparoscopic ovarian drilling is done for which condition? So, laparoscopic ovarian drilling is done for PCOS. Clear? Important one-liners. What is the most common cause of hirsutism in a young female? It is PCOS. What is most common cause of rapid onset hirsutism in a young female? It is androgen secreting ovarian tumor. The score system which you use in hirsutism, what is that called as? That is called as Ferryman-Gallwey score. Ferryman-Gallwey score. Right? What is the drug of choice for hirsutism? Who's going to tell me the drug of choice for hirsutism? What is the drug of choice for hirsutism? Jaldi batao, drug of choice for hirsutism in a patient of PCOS. I am just waiting 2 minutes for your answers. Excellent, Jaya. It is OCPs. Again, when you are going to use OCPs, you have to remember it has to belong to third or fourth generation. Now, OCPs have to be used for 6 months. If in 6 months there is no relief, then in that case, along with OCPs, you are going to add spironolactone. Right? The other drugs which you could have added are flutamide, finasteride, cyproterone acetate, right, ketoconazole. And the drug which has to be used as a last resort, which I was telling you today morning, is continuous GnRH. When you use continuous GnRH, then LH, FSH values will decrease. Because LH will decrease, so now LH will act less on theca cells to produce androgens. Now they are going to ask you this question: all of the following drugs are used in managing hirsutism in a patient of PCOS except. उस except का answer will always be danazole. Why danazole? Danazole because danazole leads to hirsutism. So you can never use danazole to treat hirsutism, right? Next very important question is, see over here the difference between the size of the follicles on both these ultrasounds. In ultrasound A, you can see the size of the follicles is small. When size of the follicles is small, that means you are dealing with PCOS. But same situation if you get, and you get big sized follicles which are almost filling the entire ovary, that means you are dealing with OHSS. Right? Next question. Now, a patient with breast cancer treatment with tamoxifen. She now presents with complaints of bleeding per vagina. What is the most likely cause? Now, I want all of you to remember that tamoxifen leads to endometrial cancer. Tamoxifen is one of the risk factors for endometrial cancer. Please remember that. Very, very important. Right? Then, a patient is taking treatment for infertility and she was given ovulation trigger. Ultrasound shows some ascites and image is given below. What is this? Ovarian hyperstimulation syndrome. Please remember that the most common drug which leads to OHSS is HMG. But the trigger for OHSS, which drug triggers OHSS? The trigger for OHSS is HCG. Whenever you are going to get image of OHSS, you are going to get large follicles, plus the question will say that there is history of IVF. So you had given some drug for the purpose of IVF. That history is going to be present whenever they are going to give you an ultrasound of OHSS. Clear to all of you? Now, next important question which I want you to remember about PCOS is, what are the long-term complications of PCOS? What are the long-term complications of PCOS? Now, in a patient of PCOS, because number one, there is increased insulin resistance, that is why there are increased chances of diabetes. Number two, you have increased estrogen. Now, because of increased, because of increased androgens. They have increased androgens, right? Now, because of increased androgens, what are you going to get? Because of increased androgens, there is going to be dyslipidemia and increased chances of coronary artery disease in future. Number three, because of increased weight, that is due to obesity, your patient is going to have psychiatric problems like depression. Your patient will have psychiatric problems like anxiety. Your patient can have sleep apnea syndrome. Your patient can in future have metabolic X syndrome. Number four, due to increased estrogen, and this increased estrogen will be seen in obese females, there is going to be increased chances of endometrial cancer and increased chances of ovarian cancer plus minus. Some studies say there are chances of ovarian cancer, some say there are no chances of ovarian cancer. And there are increased chances of non-alcoholic steatohepatitis, NASH. So these are the long-term consequences of PCOS. If they ask you what is the drug of choice in PCOS for insulin resistance, drug of choice for insulin resistance is metformin. What is the drug of choice in PCOS for irregular cycles? Drug of choice in PCOS for irregular cycles again is OCPs, right? So this is what you have to remember in PCOS. Other than this, in PCOS, I want you to remember which hormones are increased, which are decreased, and which are unchanged. Very, very important table, right? So which hormones are increased? Number one, androgens are increased. In androgens, definitely testosterone levels are increased, and to some extent DHEA sulfate is also increased. Although DHEA sulfate is formed by the adrenal glands, still there is slight increase in DHEA sulfate. Number two, insulin levels are high because of insulin resistance. Number three, what is high in these patients is LH levels are increased. Number four, because androgens are increased, that is why LDL is increased. Please remember HDL is decreased. Then FSH levels are normal in patients of PCOS. Now you tell me, what happens to anti-Mullerian hormone in patients of PCOS? What happens to anti-Mullerian hormone in patients of PCOS? What happens to anti-Mullerian hormone? Will it be increased, will it be decreased, or will it be normal? Batao, anti-Mullerian hormone. So many follicles are present. Chote follicles are present. So what will happen to anti-Mullerian hormone? Increased. Anti-Mullerian hormone is increased. What happens to progesterone levels in PCOS? Progesterone levels are decreased in patients of PCOS, right? Then, what happens to sex hormone binding globulin? So remember AMH, this is something which you tend to forget. So what happens to sex hormone binding globulin? Sex hormone binding globulin levels are decreased in patients of PCOS, right? What happens to prolactin levels? Nothing. Prolactin levels are normal. Thyroid levels are normal. What happens to estrogen levels? Estrogen levels in patient of PCOS, they are generally normal. So in thin patients, estrogen levels are normal, but in obese females, E1 is increased because androgens will be converted into estrogens in adipose tissue. So that depends upon whether the patient is thin or she is obese. In thin females, estrogen levels will be normal. In obese females, estrogen levels would be high. And which estrogen level would be high? E1 would be high, right? Some important things which I want to tell you about natural estrogens. Please remember the most common natural estrogen is E2, right? That's most common. This is most common estrogen in reproductive age females. It is E2. Most common in a pregnant female, again it is E2. But most specific in a pregnant female is E3. Most specific in a pregnant female is E3. Most common estrogen in a menopausal female is E1. Please remember, normally E2 is to E1 is 2:1. In obese females, in PCOS females, this becomes 1:2. Next important thing which I want you to remember is about the potency of these hormones. So of these estrogens, the most potent one is E2, followed by E1 and E3. Now the ones which you are using in synthetic estrogens, the synthetic estrogens which we are using is ethinyl estradiol and conjugated estrogen. Now, in comparison to all natural estrogens, most potent is ethinyl estradiol. So, most potent is ethinyl estradiol. Then it is conjugated estrogen. Then it is E2, E1 and E3 in this order, right? So, always synthetic estrogens, they are always more potent than natural estrogens. Clear to all of you? Any confusions in estrogens which you have? Okay. Coming to Asherman syndrome. All these are very, very important questions. Coming to Asherman syndrome. As I told you, Asherman syndrome, what does that mean? It means that there are intrauterine additions plus there is a defective endometrium. Now, what is the most common cause of Asherman syndrome? Most common cause of Asherman syndrome is excessive curettage. Excessive curettage. And when is the risk highest? The risk is highest when you do a postpartum curettage. What is the most common group of symptoms which you get in Asherman syndrome? The most common group of symptoms which you get are menstrual symptoms. But if they ask you what is the most common symptom, single most important symptom is infertility. After infertility, it is secondary amenorrhea, and after secondary amenorrhea, it is hypomenorrhea, right? Hypomenorrhea. What do you mean by hypomenorrhea? Hypomenorrhea means scanty bleeding. Now, what is the investigation of choice in case of Asherman syndrome? Whenever I want to look inside the uterus, the investigation of choice becomes hysteroscopy. What is the management? Management is I am going to take hysteroscopy, and with hysteroscopy I will do hysteroscopic adhesiolysis. So I will cut the adhesions using hysteroscope. Now, because uterine cavity में anterior wall and posterior wall, they are always opposed to each other unless and until something is present in the cavity. Only if something is present in the cavity, then the anterior and the posterior wall separate. So once I do adhesiolysis, there are high chances that adhesions will be formed again. That is why, to prevent the adhesions from forming again, I am going to insert a pediatric Foley's catheter. Insert a pediatric Foley's catheter. Now, all this has taken care of the adhesions part of Asherman syndrome. Asherman syndrome is not just intrauterine adhesions. Asherman syndrome में एक और प्रॉब्लम होती है कि एंडोमेट्रियम थिन है, तो एंडोमेट्रियम को बिल्ड करने के लिए कौन सा हार्मोन यूज करेंगे? ईस्ट्रोजन. बट एम आई गोइंग टू गिव ईस्ट्रोजन अलोन? नो. If I give estrogen alone, that is going to result in endometrial cancer. So I will give estrogen and progesterone for 3 months. Why am I doing this? To build the endometrium. Please remember, in Asherman syndrome, LH, FSH and estrogen, all these three are absolutely normal. Right, their levels are absolutely normal. Estrogen progesterone challenge test का result क्या आता है? Estrogen, I told you in the previous session that estrogen progesterone challenge test in case of Asherman syndrome is negative. What do you mean by that? Ki no matter how much estrogen I am giving, no matter how much progesterone I am giving, and I am stopping them, then too the withdrawal is not happening. That means ki endometrium hai hi nahi, ya something is preventing the endometrium from falling, and that something is the additions. Additions are not allowing the endometrium to shed. So no matter how much estrogen I am giving, no matter how much progesterone I am giving, and I am stopping, but my patient is not bleeding. That is what is meant by estrogen and progesterone challenge test negative. Now, what is the screening test for Asherman syndrome? The screening test for Asherman syndrome is hysterosalpingography. Coming to important points on hysterosalpingography. Hysterosalpingography, or what is in short called as HSG. Very important investigation, just पे you get a number of questions. Now please remember, HSG is the investigation of choice for knowing whether the fallopian tubes are patent or not, right? When do you do HSG? HSG is done between day 7 to day 10 of the cycle. Always it should be done before ovulation, because if it is done after ovulation and by chance your patient has conceived, when you will put the dye, there is going to be abortion. That is why it always has to be done in the pre-ovulatory phase. What is a contraindication for HSG? Obviously, if my patient is pregnant, I will not do HSG. If there is any infection in the tube, whenever there is infection in the tube, and if I am going to pass a dye, and that dye, if it is going to come out, it is going to lead to spread of the infection. That is why in case of salpingitis, and that is salpingitis means PID, or in case of genital TB, you are never going to do HSG. What dye is being used in HSG? This is your question. They have asked you. You use a water-soluble iodinated dye. Water-soluble iodinated dye, that is urographene. What instrument do you use? You use an instrument which is called as Leach-Wilkinson cannula. Leach-Wilkinson cannula. With the help of this instrument, I am going to put a dye, and then I am going to see whether the I'll do a serial X-ray to see whether the dye is coming out or not. Right? The important point about this cannula is that it has got a funnel-shaped proximal end, which has got transverse serrations like this. Right? This is how a Leach-Wilkinson cannula looks like. Right? Now, I want all of you to look at this HSG image. In this HSG image, what are you seeing? In this HSG image, you are seeing that there are so many areas where the dye has not gone. This over here is Leach-Wilkinson cannula. Dye has gone inside the uterus, and then I can also see it coming out, right? But I can see that there are multiple places where the dye has not gone. This is what is called as multiple filling defects. Multiple filling defects, right? Same I am seeing over here. I am seeing that there are filling defects. Now, whenever there is a filling defect, either the filling defect can be something like this. This kind of filling defect is a defect where you are getting multiple defects. The most important point about these defects is that they have irregular margins. Multiple filling defects with irregular margins. This is what is called as moth-eaten appearance. And this is the kind of appearance which you get in Asherman syndrome. So whenever there is going to be Asherman syndrome, this is the kind of appearance which you are going to get, right? Now compare this kind of defect with this defect. अब बताओ यहाँ पे क्या दिख रहा है? यहाँ पे हमको सिंगल डिफेक्ट दिख रहा है, प्लस इसकी मार्जिन्स देखो कितनी वेल डिफाइंड मार्जिन्स हैं. This is how you are going to get whenever there will be a fibroid or a polyp. So whenever there is going to be a fibroid or a polyp, you are going to get a single smooth filling defect. Right? Now, if you think these type of questions are not asked in your exam, again you are mistaken, because these two questions have been taken from your PYQs. Identify the image. What are you seeing over here? You are seeing a filling defect. Do you see a single smooth filling defect? No, it's not a smooth filling defect, although it is appearing single, but it's not a smooth filling defect. So this has to be Asherman syndrome. Clear to all of you? Yes. This was your PYQ. Again, this is your PYQ. This instrument is used for, this is a Leach-Wilkinson cannula, and where do you use? You use it for hysterosalpingography. Clear? Chalo. Now look at this question. A couple has come to you with complaint of infertility. On examination, her husband has gynecomastia and tall stature. Please remember, whenever you get a question where the male person is tall, where male person has gynecomastia, plus they are presenting to you with infertility. This is Klinefelter's syndrome. So you get a male who is tall, who has gynecomastia and infertility. This is 47XXY. In Klinefelter's syndrome, you get small hypoplastic testes. Right? That is what is Klinefelter's syndrome. Then you have a question over here where you had to match the karyotype. In MRKH, what is the karyotype? They are normal females. Swyer's syndrome, what is the karyotype? 46XY. Androgen insensitivity, 46XY. Turner's syndrome, 45XO. This was again a pretty simple question which was asked. Right? Now, coming to infertility. In infertility, what is the definition? Definition of infertility is inability to conceive. Inability to conceive even after 1 year of unprotected intercourse. Very, very important definition. So many times you get questions from the definition itself. But please remember that if the age of the female partner is more than 35 years, then do not wait for 1 year. Do not wait for 1 year. In this case, you have to start investigating after 6 months. You have to start investigating after 6 months. Clear? Now, whenever an infertile couple come to you, I have told you that there are 3 basic investigations which you have to do. What are the 3 basic investigations which you have to do whenever an infertile couple come to you? What are the 3 basic investigations? Quickly tell me. I have told you in class also, in marrow notes also, 3 basic investigations which have to be done in all patients whenever a couple comes to you with infertility. What are they? Jaldi batao. Waiting for your answers. Number 1, semen analysis. Right? Infertility के patient में pregnancy test क्यों करोगे बेटा? Patient infertility की आ रही है. Number 1, semen analysis. Number 2, you have to do a test for ovulation in the female, which generally is serum progesterone levels. Number 3, you have to do a test for tubal patency to see whether the tubes are patent or not, and that you do HSG. Please remember, Serum progesterone levels, they have to be checked on day 22 of the cycle, and HSG has to be done between day 7 to day 10 of the cycle. Now, whenever we are talking about female infertility, in female infertility, there are ovarian causes, which are most common cause, and then the second most common cause is tubal cause. In ovarian cause, we have discussed two causes, that is, one of them was PCOS, which we have discussed, and we have also discussed POI, that is primary ovarian insufficiency, right? So everything about PCOS, about the anovulation part, about the drug of choice for anovulation, everything we have done. Now let us talk about tubal cause. Now tubal cause could be endometriosis, tubal cause could be PID, tubal cause could be salpingitis. All these things, they lead to tubal block. Ultimately, all these things, they lead to tubal blockage. Now, if I want to know whether the tubes are blocked or not, the investigation of choice is HSG. HSG. But HSG is not the gold standard. Gold standard for knowing whether the tubes are blocked or not, you should see the tube from your own eyes so that the exterior of the tube can also be seen. You should see the dye coming from your own eyes. That means it is laparoscopic chromoperturbation. Laparoscopic chromoperturbation. Right? Now, laparoscopic chromoperturbation mein what do? In laparoscopic chromoperturbation, you are going to pass the dye, right? And with the help of the stethoscope, you are going to see whether the dye is coming out or not. That is laparoscopic chromoperturbation, right? Now, a question was asked in your exams that a lady with infertility undergoes laparoscopy for assessment of her fallopian tube. Chromoperturbation was done. Dye was passed. The dye which is used for performing chromoperturbation is. So the dye which is used for performing chromoperturbation, who's going to tell me? Dr. Brodeen is saying methylene blue dye. Okay, most of you are saying methylene blue dye. Which dye is being used? All of you methylene blue dye? Yes. So the dye which is used is methylene blue dye, right? Now, when you do tubal patency, tubal infertility, when you do HSG, as I told you, you can get a unilateral block or you can get a bilateral block. Whenever you get a unilateral block, it should be managed like unexplained infertility. And management of unexplained infertility is clomiphene citrate plus IUI. Clomiphene citrate plus IUI. Right? Then, if it is a bilateral block, then it can be a proximal block or it can be a distal block. Depending upon kaisa block hai, then the management will happen. So, if you are getting this HSG, in this HSG, what are you getting? In this HSG, you are seeing that there is a cannula, that is Leach-Wilkinson cannula. The dye has gone inside the uterus and it has gone up till the angle of the uterus. Beyond the angle of the uterus, the dye has not gone, right? This is what is called as a bilateral cornual block, right? This is what is a bilateral cornual block. Now, whenever they ask you a question, what is the most common cause of bilateral cornual block? Please do not say it is genital TB. This is an image of bilateral cornual block. It is not uniconnovate uterus. Uniconnovate uterus mein you can see one fallopian tube. Here you can't see any of the fallopian tubes, right? This is a bilateral cornual block. Now, most common cause is when you were passing the dye, the tube had undergone spasm, and because of which it is appearing that there is a bilateral cornual block. Actually, there is no blockage. Actually, the tube has undergone spasm, right? So, the most common cause of bilateral cornual block is physiological spasm. Most common pathological cause is genital TB. Now, whenever you are getting a bilateral cornual block, या जब भी कोई भी block मिलता है, in order to confirm, you have to do the gold standard test, and the gold standard test is laparoscopic chromoperturbation. ये तो हमें पता है. अब when you are getting a bilateral cornual block, along with this, इससे पहले कि हम laparoscopic chromoperturbation करें, I am going to take a guide wire and I am going to look through hysteroscopy. So with the help of hysteroscopy, I am going to take a guide wire, and that guide wire I am going to pass into the tubes. When I will pass that thin wire inside the tubes, जहाँ कहीं पर भी spasm होगा, that spasm is going to get relieved. And then I am going to pass a dye and see with the help of laparoscope whether the dye is coming out or not. So whenever they ask you a question that what is the management of bilateral cornual block, you should always say that the management is laparoscopic chromoperturbation plus hysteroscopic cannulation. अब इतना बड़ा answer is never given in your options. In your option it will be written as next step is hysteroscopy followed by laparoscopy. So whenever you are getting a bilateral cornual block, next step if they ask you, it is hysteroscopy plus laparoscopy, right? इतना करने के बाद most of the blocks will be relieved because most of the blocks were physiological. But if it is a pathological block, it will persist, and in that case the best management is IVF. So all these are questions which are asked. They are going to show you this HSG and they are going to say what is the most common cause of this HSG. Don't say genital TB. You are going to call it as physiological. Most common pathological cause is genital TB. What is the next step? Hysteroscopy, laparoscopy. What is the best management? IVF. समझ में आ गया ये वाला HSG? Now they can show you this HSG and they can ask you, what is this HSG showing? Now what is this HSG showing? This over here is the Leach-Wilkinson cannula. It's the Leach cannula. Now the dye has gone inside the uterus. Can you see the dye has gone inside the tubes also? The distal part of the tube is swollen and I can't see any spilling of the dye. So what I am seeing is that there is a bilateral distal block plus there is hydrosalpinx. A bilateral distal block with hydrosalpinx. Now whenever they give you this image and they ask you what is the next step, as I told you, HSG is only the investigation of choice. Gold standard investigation always is laparoscopic chromoperturbation. So whenever I am getting a block, my next step is laparoscopic chromoperturbation. In this case, you don't have to do hysteroscopy. Now, if it is a bilateral mild block के लिए we do fimbrioplasty. If it is a severe block, I will go for IVF. Whenever I have to do IVF and I can see that there is hydrosalpinx, please remember ये जो fluid होता है ना hydrosalpinx का, this is very fetotoxic. मान लो मैंने IVF कर दिया and मान लो the fetus has started developing, pregnancy has occurred. This fluid can trickle down and it can lead to abortion of this fetus. That is why before I do IVF, I have to make sure that this fluid does not come inside the uterus. And because the tubes are swollen, they are of no use now. So before I do IVF, I am going to do salpingectomy. I will be doing a salpingectomy followed by IVF. Right? That is what you have to do in case of hydrosalpinx. Management is IVF, but before IVF, you will have to take care of the fluid which is present in the dilated part of the tube. Clear to all of you? Next question which they ask you is, epithelial lining of fallopian tube. This was once a question which was asked in your exams. All of you know it's ciliated columnar epithelium. So in female infertility, they focus on tubal factor infertility and ovarian infertility. Just one more thing, if they ask you what is the management of unexplained infertility? Management of unexplained infertility is clomiphene citrate plus IUI. That is the management of unexplained infertility, right? Now, what is immotile cilia syndrome called as? Whenever there is going to be immotile cilia, right, there is going to be infertility. And what is that called as? That is called as Cartagener's syndrome. Cartagener's syndrome, right? So these are the questions which they can ask you on female infertility. As far as male infertility is concerned, I am not going to take it up just now because it is already going to be 5 and you have a session of orthopedics which is going to happen. So now all of you should join the orthopedic session, and gynae remaining part I am going to cover it up tomorrow morning. Tomorrow morning I'll put up the schedule. Either it is going to be at 9:30 or 10, the last part of gynae ATP session. Right, so see you all tomorrow morning. Time and all the other details I will inform you on the SSS Telegram channel. All the DBMCI FMG bachas, I am going to take your session tomorrow. I'll let you know whether I'm going to take it face to face or whether it is going to be through this YouTube live session. Right, so now all of you should be joining the orthopedic session. Thank you so much. What do I have to clear? Jaya, can you ask your doubt on the SSS group beta? Right, so ask your doubt on SSS group, I'll answer there. Where did I tell continuous GnRH? Where have I said continuous GnRH where it is creating a confusion? Jaya, in which condition where have I said instead of pulsatile GnRH, where have I said continuous GnRH? मेरे को ये तो बता दो. Where has that slip of tongue happened? I'll go through the session if there is some slip of tongue. In PCOS, acha, in PCOS it is pulsatile GnRH. Just let me see. PCOS में have I said continuous pulsatile लिखा है बेटा. It's pulsatile GnRH. भाई you want it for ovulation ना? हमें ovulation के लिए देना है तो ovulation के लिए we have to use pulsatile GnRH and I have written pulsatile GnRH. I have written pulsatile GnRH over here. I haven't written continuous GnRH. Last resort. अच्छा, you are talking about hirsutism. Hirsutism में last resort. एक मिनट मुझे जाने दो. अब बताओ. देखो तुम लोग ना रट बहुत रहे हो. You are not understanding. Whenever you want LH, FSH and estrogen to increase, you will give pulsatile GnRH. तो ovulation के लिए क्या चाहिए? Ovulation के लिए I want LH and FSH to increase, right? So I am going to give pulsatile GnRH. अगर पेशेंट हमारे पास इनफर्टिलिटी की कंप्लेन लेकर आ रही है, इन केस ऑफ PCOS, you have to give pulsatile GnRH. बट अगर पेशेंट हमारे पास हिर्सुटिज्म की कंप्लेन लेकर आ रही है, in a case of hirsutism, I want androgen levels to decrease. An androgen level will decrease when LH is decreased. So I will have to give continuous GnRH. So for management of hirsutism, you have to give continuous GnRH. For management of infertility, you have to give pulsatile GnRH. दोनों जगह पे सही लिखा है, कहीं पे कुछ भी गलत नहीं है. Right? Understand the concepts. And then you will never have to mug them up. Link for SSS group. So you can search study with Dr. SAKSHI and Dr. Sushil and you will get it on the Telegram group. Right? And that is where I will share the annotated PDF as well. Yes, Nagma, typhoid vaccine can be given to a female who's traveling abroad in an endemic area. Typhoid, cholera, yellow fever, polio vaccine. All of them can be given if a female is traveling to an endemic area. Right? Chalo. Okay, take care all of you. See you tomorrow morning. Time and everything, I'll let you know. That's okay, Jaya. These sessions are there to clear your doubts. Thankfully, you've asked your doubt. So you don't need to be sorry, and thank you so much.